Welcome to CharityVillage Connects. Today we're talking about the mental health impacts that the pandemic has had on the nonprofit sector. And we have a superb guest to help us understand the issues and the possible solutions. Steve Lurie has enjoyed a long and influential career as the Executive Director of the Canadian Mental Health Association Toronto branch. Now retired, Steve is an adjunct professor at the Faculty of Social Work at the University of Toronto. He continues to write and lecture extensively on mental health policy issues. Steve was awarded the Canadian Mental Health Association's CM Hinks Award for National Leadership in Mental Health and the President's Award for Outstanding Contributions by Addictions and Mental Health Ontario. He was recently named to the Order of Canada for his contributions as a leader, scholar, and advocate, and was honored by CMHA as one of Canada's difference makers in mental health and addictions. Welcome, Steve.
Hi, glad to be with you.
You've enjoyed a long career, an illustrious career in the nonprofit sector and in mental health advocacy. Can you describe the unique mental health challenges that professionals who work in the sector generally experience?
Well, you know, if you're working in mental health, obviously you see examples of resilience, but people come to you because they're having problems. And some of those problems are long-term and appear to be intractable. And the recovery journey is never linear. There can be, steps forward and then steps back. So the people who work in mental health, particularly community mental health, need to be quite resilient. They often see people at their worst, and then they have to both give hope and be able to help people in terms of skill building, basic empathy, move forward on their recovery journey. Over time, that can take quite a toll on staff because, again, they're seeing people struggling with difficulty. And I think at the same time that most people working in mental health, and I certainly know this from when I worked at CMHA, that the staff were really, really dedicated, and we often heard from our service users about how incredible the staff were, how they never gave up on people. And so that's a really important feature of working in mental health, that you have to believe in human possibility. But at the same time, if you do it year after year after year, sometimes you can approach burnout. Sometimes you'll experience critical incidents that stay with you. I remember one of our staff who was working in our housing program came upon one of our clients who unfortunately had passed away in his apartment, and he was in a state of decomposition when he was found. And she said, like, for 6 months afterwards, she could smell what she encountered. That memory kept coming back to her. So I think there's potential for a post-traumatic stress disorder, and certainly the Mental Health Commission and others have noted that people on the front lines, whether it's the pandemic or whether it's police, firefighters, mental health workers, hospital workers, can experience post-traumatic stress. So I think this is where organizations need to be attentive to this and develop programs to deal with vicarious trauma, build that knowledge and support into their staff supervision. And if they do that well, the dedication of the staff working in the sector is ultimately sustained and rewarded.
And so what does that mean in terms of vicarious trauma and being able to provide that support by the employer to help the workers, the frontline workers, build that resilience?
Well, I mean, there's a whole field of study about vicarious trauma, but it gets to the point I raised earlier, where people can experience traumatic distress based on the situation of the people they're working with, and so you need to be able to build that resilience in staff. You need to be able to for managers, they need to be able to assess when people are not necessarily attending to work as they should. Often an early sign of this is increased absenteeism or apathy or cynicism. But again, most people who work in the sector don't demonstrate that day after day. Most people are quite resilient. They've gone into the field because they want to help. And so what employers need to do is get familiar with what vicarious trauma is and the techniques that can be used in both small and large organizations to counteract. For example, there's a program that CMHA National developed called Not Myself Today, and that's it's a free resource on the CMHA National website. It's an opportunity for teams to talk about how they're doing personally. And you get these little pins that show, whether you're happy, whether you're meh, whether you're distressed. And there's a toolkit for having discussions within a team because it not only does what people experience in their work environment affect how you function, but also it recognizes that people may be going through issues at home. And so this is an opportunity to talk about them. And obviously, an adjunct to that is that employers need to know that there are certain things that, teams aren't set up to do psychotherapy. So what are the psychotherapy resources in the community that are available to staff? Does the organization have an employee assistance plan and things like that?
Now, as you've sort of alluded to, really, mental health issues in the nonprofit sector is not a new issue. It's not a new problem. Can you sort of give us a bit of background in terms of the challenges that professionals in the nonprofit sector have suffered in terms of being in a circumstance where mental health issues can arise in their workplace and in their work day?
Well, I think some of that we have to back up and say, so what's the incidence of mental health problems in society in general? And according to the Mental Health Commission, we know that by the time any of us reach age 40, 50% of us will have experienced a significant mental health issue. And if we're fortunate enough to live to age 90, 70% of us will. And so that means that, having mental health problems isn't unique and rare. It's actually quite common. And then if you think about that notion of if it's 1 in 2 people by age 40, even if you're not one of the people experiencing it, you're a family member, you're a friend. So it's all around us. And it runs the gamut from moderate to mild anxiety and depression to more serious issues like schizophrenia and bipolar disorder, which of course occur in a much smaller portion of the population. But mental health issues, don't target certain people. It's ubiquitous. It's all around us. So I think in the mental health sector, the fact that we're talking about large numbers of a population at any one time. I mean, the mental health sector is targeted at people who are suffering mental distress. But I think you also see it in other sectors that, the not-for-profit world works in. I mean, particularly seniors. I mean, a lot of people work in home care and social care. And we know that, besides dementia, which, becomes a big issue once people reach 85, prior to that, and I remember, 25, 30 years ago, Dr. Marie-France Rivard, who was the expert in psychogeriatric psychiatry, telling me that the big problem for mental health in the elderly was depression. And that's caused by loneliness, loss of partners, loss of social networks, physical health issues that are cropping up. So, I think we have to be attuned to the fact that mental health issues, even pre-pandemic, have been with us, since time immemorial. And unfortunately, access to mental health services is still problematic across the country, whether it's, for employees who are experiencing mental health difficulties or the general public. We've seen improvements, but, I have a recording of the late Dr. Claire Hinks, who started CMHA in 1918, and he talks about that this problem of mental health issues or mental illness, puts more people in hospital than other physical health disorders. That's still true today. The rate of mental illness is 1.5 times that of cancer and heart disease. So I think what we need to accept is that, mental health problems, similar to physical health problems, is part of our overall human makeup. And it doesn't matter what sector you work in, you're going to experience it either in the people you're working with as a helper or your colleagues. And what we need to do is do a much better job about making sure that the resources people require to cope better are available. And that's everything from online supports, the apps that are now available, telephone support, to clinical interventions by mental health professionals.
Well, that's fascinating sort of glimpse into the history of how our society has been addressing mental health issues. But let's bring it to today. The pandemic hit Canada in early 2020, and it became clear fairly quickly afterwards that the nonprofit sector was particularly impacted, with the organizations and professionals being uniquely vulnerable. Can you describe what you learned about COVID's impact on mental health for the people that were working in the nonprofit sector?
Yeah, well, first I think we need to start with what was the impact of COVID on everybody. And some of the surveys that were done, Angus Reid did a survey last fall, and found that 27% of people said they were struggling, 44% said they were worried, 41% said they were anxious, 16% said they were depressed, 50% said their mental health had worsened, and that was just the general public. You add to that the work of our colleagues in the not-for-profit sector who are working with vulnerable populations, who may have been seeing exacerbated problems, were also challenged to adapt the way they worked. Personal contact was limited. There was the fear, particularly pre-vaccines, of contracting COVID. There were early on there were concerns about the availability of protective equipment, PPE. Organizations, had to figure out how to manage infection control, and there's still debate about airborne versus droplet spread. So, in a community agency, which unlike hospitals doesn't have an infection control department, you had to scramble and you had to figure out, what kinds of services could you provide in person, what were you going to do online, what were you going to do by phone. Now, one of the things that was observed in the pandemic is that many organizations who moved to more online and telephone-based services actually saw an increase in service provision. But that also created some issues too, because it wasn't like their resources increased to provide more services, but lots of people wanted them because of the convenience factor. So I think particularly small organizations had to scramble, and and I think there were levels of challenge. For example, if you were running a residential program, whether it was for seniors or whether it was for people with mental health and addiction problems, you couldn't close the program and say, okay, well, now we're going to make you homeless. You had to figure out how to implement infection control within the setting, and it's not like the government showered money on NGOs to redo their ventilation systems. Luckily, by last summer, there was funding available, for PPE, certainly for the health-funded agencies, and I'm assuming, ministries of social services across Canada also stepped up. But, these put particular pressures on smaller organizations and even larger organizations, because the staff had to figure out how to provide services in a different way. But at the same time, staff were also dealing with their own situations, like, were their kids able to go to school? And if their kids weren't able to go to school, how did you manage the homeschooling plus the need for you to be on Zoom, or the need to do visits? We also uncovered other unmet needs in the process. I know that when CMHA began to roll out its pandemic supports, one of the things we identified was food security was a huge gap. And we had to start implementing a food box program, which added another, $12,000 cost annually to the budget. Luckily, the federal government and United Way of Canada stepped up and provided support to us, and many other organizations across the country. But again, food security wasn't something that we were even thinking about pre-pandemic.
So, you've painted a very clear picture of this circumstance where there was already issues around mental health in the society at large and within the nonprofit sector. And then on top of that, that's the pandemic came and also created, more pressures and more need for people within the nonprofit sector to continue to serve within their roles and deliver to the community that was going through this terrible crisis. So, in the whole process of which they are struggling, and organizations are struggling to be able to support their employees and their workers to continue to do their jobs and give back to the community. So maybe you could talk about what you've learned that nonprofit organizations can do to help support their staff, whether these multiple mental health issues, whether it's depression, anxiety, burnout, or other kinds of problems.
Yeah, well, I think we need to start with what are people who are knowledgeable about community psychology telling us about the effect of the COVID pandemic on the general population, and I've been fortunate to be in touch with two really great resource people. One is Dr. Nagasawa, who at the beginning of the pandemic wrote a publication called Tolerance for Uncertainty, and she talks about the importance of healthy coping. So you need to still maintain contact with family and friends. You need to have well-balanced meals. You need to increase physical activity. Sleep hygiene is important. But she also poses the notion of what she calls radical acceptance, which says you can't fight reality. So you have to stop fighting reality. So and that I think is particularly relevant today when we're saying, well, when is this going to be over? Well, we don't know when it's going to be over. So we have to manage it as we know it now. And so, let go of the bitterness and figure out how you're going to do the best you can. And then the other day, Dr. Leslie Weisenfeld from Mount Sinai was talking about a few things. I mean, she basically said that humans are inherently resilient, and I think we have to believe that most people, will find a way out, and we're also adaptable. But she talks about the 3 C's. Meaningful connections, opportunities for contribution, and then similar to what Dr. Nagasawa talks about, recognize what we can't control. So, for all of us, I think those are ways of trying to manage a difficult situation where we don't know how long it's going to go on for. But for organizations, I think that's where they need to think about, do they have employee assistance plans? Do they have capacity for critical incident debriefing when, for example, a staff member or a client gets ill from COVID or dies? Do they have procedures and approaches to compassion fatigue? And I think for small organizations that probably seems like, well, geez, we're just struggling to keep the doors open and to deliver service in the way we've had to shift during the pandemic. But that's where I think thinking about regional and provincial collaboration, so that groups like ONN here in Ontario, the Ontario Not-for-Profit Network, could bring people together and say, what resources do we have to help people cope and continue to work. And this was happening actually at the local level, and likely still is. I mean, I know that here in Toronto, the city and United Way collaborated to put tables together, both very locally, so in Scarborough, as well as on a citywide basis, where NGOs of all stripes got to talk about how they were managing the pandemic, whether it was PPE, whether it was vaccinations, whether it was supporting staff in new ways of service delivery, dealing with reopening issues at the office. So I think organizations need to be reflective on that. What have we learned in the last 18 months? What's worked? What hasn't worked? We do know, for example, that, as I said earlier, online and telephone-based service provision has dramatically improved access in many cases, and people find it convenient, and most people have access to a cell phone. Now, at the same time, if you're going to be thinking about cell phone access to service, you also need to make sure that the people you're serving who don't know how to use a cell phone or don't have one get one. And there are some barriers there. TELUS had a temporary program where they were making cell phones available, for 3 months to NGOs, but obviously we're 18 months in. So I think this is also where philanthropy needs to step up and government needs to step up. And in particular, I think this is an opportunity as governments start to think about, the Build Back Better notion. How can they support the NGO sector where, quite honestly, we hear a lot about, the frontline healthcare workers in hospital, but I'd say the frontline workers who were supporting seniors, who were doing mental health work in the community, they're also unsung heroes, and they deserve support, not only, adequate funding from government, but government also needs to think about what kind of infrastructure do we need at the regional level to support staff in doing the work? How do we prevent burnout? And at the same time, as I mentioned earlier, there are programs like Not Myself Today, where there are toolkits that are available online. Employers can make use of them. The Mental Health Commission has developed resources. CMHA National has a program. CMHA Ontario has Mental Health Works. And so I think people need to look at how do we leverage what's out there, but at the same time, the notion of collaboration, we can do more by collaborating with others than we can do on our own. And so I think that needs to drive this. And I suspect that many folks, even if they're feeling pressed by the last 18 months, they also are looking for opportunities to share what they've learned and to work with others, perhaps to reduce some of the barriers that they've encountered in delivering services during the COVID environment.
So perhaps you could give some practical steps or advice that leaders could take of small nonprofits to support their people. I mean, we know that the vast majority of nonprofits out there are, in fact, quite small and wouldn't have the kind of robust infrastructure that might include an employee assistance program. What advice would you have for leaders of those organizations?
Well, again, I think part of this is to identify what are the free supports available, online. And so, for example, the Not Myself Today toolkit that allows people to have conversations in their staff teams about how people are coping, and then some practical tips about how to help people who are in need of assistance. So you need to start, with something like that. And even if you don't use Not Myself Today, I mean, just checking in with your teams on a regular basis about how they're doing. And there's a program in Brazil where, and Brazil isn't a well-resourced mental health jurisdiction, where they basically bring communities together just to talk about how people are coping, whether it's with it began with discussions about mental health issues, AIDS, and now it's been COVID. But there's wisdom in groups. So I think part of this would be, if you're a small employer, at least bring your staff together to talk about how are we doing, and how can we help each other, and what more can we do. I think at the same time, as I mentioned earlier, there are locally, certainly in the GTA, and I would assume in many of the larger urban centers across the country, governments in United Way have convened tables to talk about what are the effects of COVID and how do we move forward and what resources can be shared. And so I think small agencies, need to identify, what are the opportunities in our communities to do better work together. I know that one of the things that the hospital sector in Toronto did, and I would assume that this might have occurred across the country, is they recognized that within the geographic zone of a general hospital, there were many small community agencies who needed help with infection prevention and control. And so there, the hospitals got the word out, just outreach to us and we'll help you out, and I know, for example, hospitals in the Toronto area were doing webinars, and some still are. So I think part of this is looking at what resources exist in your local community. I also think that groups like the Ontario Not-for-Profit Network and CharityVillage should be looking at how do you survey what's available across Canada and make it available to people who might not know that there's a resource in their community. But once again, I think some of the national organizations like CMHA National have programs that are available. There are programs like Mindability here in Ontario, and to improve access to psychotherapy. In British Columbia, Ontario, and I believe Manitoba, Bounce Back is a free service that provides people with ready access to mental health supports, to psychotherapy based on cognitive behavioral therapy for mild and anxiety or mild to moderate depression. And that's actually the evidence-based approach. Paradoxically, if you or I experienced depression or anxiety and we went to our doctor, we'd probably be given some kind of medication. The evidence out of the UK is that that's not what's required. What's required is cognitive behavioral therapy, and a program like Bounce Back has multilingual coaches that can be accessed at people's convenience. So that's another thing that small employers can look at. If you've got staff who you believe are experiencing anxiety and depression, check out Bounce Back because your employees can register for that as individuals, and then they can have access to coaching at their convenience and access to tremendous online resources as well.
That's great advice. You in previous discussions, you've described that even after the pandemic is over, that Canadians will have to address the pandemic of mental health issues. What do you mean by that?
Well, as I said earlier, I mean, if we are living in an environment where up to 50% of us will experience some kind of mental distress before we reach age 40, and 70% as we get to age 90, that suggests that even prior to COVID, we had a pandemic of mental health problems. And there are statistics that come from the community health survey that's done that show that 1.6 million Canadians were reporting unmet mental health needs, and that's probably an undercount. So that means that access to mental health services across the country is problematic. Most people, if they experience a mental health difficulty, will probably go to their family doctor. Most family doctors are not, well trained in mental health issues. Some are. And that's where the whole issue about improving access to psychotherapy beyond the medical profession, beyond psychiatry, and there are some examples across the country. In Hamilton, for almost 40 years, there's been a shared care initiative between family practice and the Department of Psychiatry at McMaster, where you can, within a day or two, if you're a family doctor and you're one of your patients is experiencing depression or anxiety, you can be connected with a psychiatrist who will provide you with consultation about treatment. And then you've got programs, again, like Bounce Back, which make it easy for people without needing to be referred by a family physician. What they ask is if you have a family physician, that gets recorded, and if you don't have a family physician, they'll connect you with one so that there can be follow-up if things need more complicated interventions. But again, the opportunity to increase access to mental health services and also provide more support. There's lots of evidence that peer support works. And so what we really need to do is focus on what are the things we've learned over the last 40 years that we know work, that could be scaled. So David Goldblum, in his wonderful book, We Can Do Better, talks about interventions with families that involve coaching that started in Nova Scotia, the Healthy Families Initiative. We know that assertive community treatment teams work very well for people with complex mental health and addictions issues. We know that early intervention and psychosis teams, after 3 years, most of the people who get that service are re-engaged in the community, going to school, going to work, living successfully, navigating the relationships with their family better, and can usually just be supported by a family physician after 3 years. So part of this, and I remember having this discussion with Minister Philpott when she took on the health portfolio early in 2016, is we need to look at how do we scale up interventions that we know work across the country. Now, the barrier is that there isn't enough money going into mental health services. I mean, paradoxically, we spend about $7,000 a year per capita, per Canadian, on healthcare annually. And we spend about $350 a year on mental health services for Canadians. Actually, increasing that spending by $85 or so would allow us to achieve the $3.1 billion annual requirement for mental health spending in the country. So even though $3.1 billion sounds like a lot of money, and governments have moved partway through the Health Accord, $500 million annually is now being invested in mental health services. But we require a minimum of $3.1 billion annually. Here in Ontario, the McMaster Health Forum has said there's an annual deficit in care of $1.5 billion a year. The provincial government has invested an equivalent of about $380 million. So there's still, a $700 million annual gap at least. So I think people need to push the notion of there needs to be more investment in improving access to evidence-based mental health care. But the good news is, at $85 per Canadian, that's not going to break the bank. And the other good news is there are a lot of things that work. So often government says, well, this is an intractable problem and the sector's divided, and so we don't need to do anything about this. But ironically, in relation to mental health, what we know and what we've learned over the last 40 years or so that I've been working in the field is that there are a lot of things that actually work. Housing First works for the homeless population. I mentioned, assertive community treatment, early intervention in psychosis. These things work. There's employment strategies that work for people with mental health issues. And actually, CMHA Toronto is running a national project in 12 sites across the country to create employment opportunities for people who are experiencing mental health issues. And that's been a tremendous success. So again, I think the good news is that it's not like we don't know what to do. We actually do know what to do. It's just we need to focus on doing it. And that requires, I think, on the part of our the sector, in terms of its advocacy, pushing government to set targets and to meet them. It's easy to say, oh, we're going to improve mental health care. And, for example, Bell Let's Talk has been very successful at sort of raising the bar around mental health is an issue and there are things we can do about it. But again, the $100 million, which is non-recurring, that they put in every year, in other words, they'll fund new projects every year, but a project that established itself in year one can't get Bell Let's Talk money in year 2, 3, and 4. So that pushes, again, the requirement that government needs to step up here and provide an adequate level of funding across the country to improve access to mental health services. And we know that if that's done, there's the Mental Health Commission has published 2 papers that are available on their website, making the case for investment in mental health and then strengthening the case for investment in mental health, which actually have lots of examples of if you implement evidence-based care, there's a payback, both in terms of reduced institutional spending, reduced pressure on hospitals, but most importantly, improved quality of life for the people who are able to get the services.
So do you think that in a strange way, the pandemic has actually shone the light on this issue that may indeed have some long-term change as a consequence, because we've become the heightened awareness of mental health issues during the pandemic has actually perhaps energized advocacy around this point where we can get long-lasting change?
Yeah, I mean, I think that's true. I mean, for example, the Globe recently did an editorial saying, mental health, the surprise issue in the election campaign, and all political parties have, put out what they intend to do to address mental health issues. But again, we need to recognize that in Canada, healthcare is a provincial responsibility. And so, for example, I can't imagine the province of Quebec being told by the federal government what they should do in mental health. But on the other hand, it would be important for the federal government and the provinces and territories to work together on how do we achieve better access to mental health services and supports in our province. And that can recognize that provinces can have different priorities. But again, I think there are some overarching themes that regardless of the province you live in, you would want to work together and to share resources and to share expertise. So I think what we need to demand of government is where does government stand, both the federal and provincial governments, on achieving the targets of 9% of healthcare spending and 2% of social spending that was advocated by the Mental Health Commission in 2009. So, this is 12 years after, and there isn't one government in the country that has made that kind of policy commitment. But if you had, and again, that policy commitment costs $85 per Canadian, so it's not going to break the bank. And so in the same way that, we have seen a commitment to a 10-year plan for childcare and early learning, we need a national commitment and a 10-year plan with spending targets and service delivery targets for improving access to mental health services across the country. And again, that can build on what we know works, and there's also been some interesting innovations even on the substance use side. In Ottawa, Dr. Jeff Turnbull has developed 2 really innovative programs. One for people who have chronic drinking problems. So it's a managed alcohol program that is combined with supportive housing, and he's now got a managed opioid program as well. And again, these are the kinds of things that can be scaled. So I think the good news is that we know that the pandemic has shone the light on people's challenges in coping with, the 18-month situation that we've had. But we also know there are amazing signs of resilience, and we also have seen some expansion of services online and also some clinical services that are available in communities. That needs to continue. That needs to be built in to the plan. But again, every single province over the last 20 years has developed a mental health and addictions plan. They've developed many. The problem has been they've suffered from implementation deficit disorder. They haven't implemented them. But there's lots of good evidence in every province across the country about where the needs are. And so what's now required is concerted effort, both at the provincial and local level, as well as at the national level, to begin to make this real. And, for example, the current government made a commitment to end homelessness. And we know that homelessness is disproportionately experienced by people with mental health and addiction problems. But the good news is if you can provide housing, and particularly if you do it in a housing first framework where you provide people with the housing of their choice and then you flex supports up and down, for 80% of people, that will reduce, if not end, homelessness. So let's just get on with it.
Well, it sounds like advocacy by the sector and by everyone in Canada will play a huge role in the recovery after the pandemic. Would you agree with that as it relates to healthcare issues?
Yes, I think it's really going to be important that particularly the NGO sector come together around the need to make investments in mental health and make investments in social infrastructure, because I think there are still the shillabiths of the past that will haunt us. If you think about the dialogue during the pandemic, long-term care, quite rightly now, is having a light shone upon it because it has inadequate facilities as well as inadequate staffing. So governments are going to say, well, we've got the long-term care problem. Maybe we can't afford to do anything about mental health, so we'll fix long-term care. People need to say that that's not good enough. And then, we've seen through the pandemic, what's driven many of the public health measures is reduce the pressure on hospitals. So it's the hospitals are us syndrome. And again, if you look at, traditional approaches to healthcare spending, we spend most of our money on hospitals, doctors, and pharmacology. And that isn't obviously you need physicians to be available to provide clinical care for people suffering with mental health issues. But we also know that there are a whole lot of adjunctive services that can be provided in a multidisciplinary way that can be very, very effective. So I think we need to recognize that the share of spending at the community level really does need to be increased. And for example, thinking about ONN colleagues who work in community care and seniors care, there's lots of evidence that if you want to avoid admissions to long-term care, you have to provide more care in the community. There needs to be recognition that, in terms of care for seniors, that services need to be provided in the community. And that's a very important thing that needs to happen. And again, there are evidence-based ways to provide improved seniors care. Lots of people have been doing it for years, similar to mental health care. So what we have to acknowledge is that basically upsizing the community sector is the way ahead in all of this.
I was very intrigued by your comments about nonprofit organizations actually coming together during the pandemic and pooling resources and trying to come up with solutions and brainstorming together and learning from each other. Is that one of the better things that might have been a consequence of the pandemic that we can learn from?
Yeah, I think so. We tend to sort of stay in our comfort zone. So, when I think of most of the meetings I went to, it was with colleagues working in community mental health or mental health more broadly. But I know, during the pandemic, one of the things that was good was that, as I mentioned, the city and United Way convened tables which fostered collaboration across sectors, and so I think we need to keep doing that. And again, that's where organizations like CharityVillage and ONN can play a large contribution, because that's your bread and butter. And I think, again, we always think that the work we do is unique and special, and it certainly is because we're doing it. But at the same time, we have a lot in common with other colleagues in the community sector, and there can be lessons learned. So for example, as I mentioned, food security emerged as an issue for CMHA during the pandemic, and we actually partnered with Circle of Care, who was providing supports as well as food security supports to seniors. And so I think that reaching across the chasm, and also looking at work we can do together. One of the issues, if you think about strategic issues around community services and mental health, is the people who are fortunate enough to get services, particularly those who have complex mental health issues, who might be living in supportive housing, or who are getting case management or other clinical supports from a community agency. The whole issue of aging in place is becoming more and more important. I've been meeting with colleagues in the supportive housing sector, and that requires some strategies, because we know that people with complex mental illness are more likely to experience early onset of things like Alzheimer's. Also, even if they aren't experiencing Alzheimer's or dementia, their physical health care is often compromised, and there needs to be work done there. So the whole opportunity to say, okay, we now have a significant number of people over 55 on our caseloads, and are there opportunities to collaborate with people who provide home and community care? Again, that will require resources, but I think there are opportunities really to reach across and work together, because actually that's what we're all in this for. I mean, nobody goes into work in the NGO sector for the great money it pays, or the notoriety and to become famous. You go into this work because you want to make your community better. You want to help your fellow neighbors and friends, and the paradox is, despite all odds, lots of people in the NGO sector, spend years and years without changing their job. They just keep doing it day after day because they believe that it's important to help their fellow members of their community. I mean, that's certainly what I experienced at CMHA. I often used to say, working for CMHA is a lot like the Eagles song, the Hotel California. You can check out anytime you like, but you can never leave. I mean, we had a significant number of people who've basically made their careers working at the Canadian Mental Health Association here in Toronto. And I think that isn't unique to CMHA. I think many organizations in the voluntary sector have people who work day in, day out, year after year after year. That's why the Bhayana Foundation has been proposing, a week of recognition for the NGO sector, because they really are the unsung heroes in our society.
Well, I was just going to ask you about that. I think that some of that public recognition is certainly what Raksha Bhayana believes can help people continue in their mission and to support the nonprofit sector, particularly around workers who might be experiencing things that are mental health issues that are, leading to burnout and potentially leaving the sector. Would you agree with that kind of role that public recognition, the awards, can do to help people in how they're coping with their mental health while doing such an outstanding job every day to help others in the community?
Yeah, I think the public recognition is very, very important because, of course, it shines a light on what's happening within the sector and in particular the contribution the sector makes. And the Bhayana Foundation for years collaborated with United Way across the country to basically identify heroes within the United Way member agency movement. And I remember we were fortunate that we had staff who were honored in that way. But what was all inspiring for me is to attend those luncheons and hear about the amazing things that people did and the creativity. But at the same time, this is similar to the Bell Let's Talk thing. We shouldn't think that, okay, well now there's a light being shone on this and all is well and good. Shining the light also means that there needs to be a commitment by government to deal with the issues that the sector has experienced, for generations. So how do we make sure that supports to employees are widely available to small agencies? How do we make sure that compensation is fair and reasonable? And there have been certainly in Toronto, there have been initiatives led by sector people, around making sure that the sector is able to pay a fair wage to the people who do the work. So I think the shining a light on the sector and recognizing that without a whole lot of resources, the sector makes an incredible contribution to the quality of life in this country. But I think we have to take it to the next level and say, if we believe that the not-for-profit sector is integral and critical to good quality of life in every community across the country, then what do we need to put in place to make sure the sector thrives and that the people working in the sector thrive? And, again, that will cost far less than having to default to institutions. And again, it can be done, as we've talked earlier, by leveraging the networks that already exist and creating networks where they don't exist. So, for example, back to, supports to employees. Every small organization doesn't necessarily need to have a coordinator for workplace supports. But if in a given locality, agencies can come together around, how do we make sure we roll out and train staff to use Not Myself Today? Can we collaboratively find unspent money every year and contract with CMHA Ontario to do mental health works projects and training within our workplace? So again, that notion of working together to solve problems, and I think and I know this has been done in some communities, but almost thinking about the annual week of recognition might be coupled with what's the state of the nation? Like, how are we doing? So what are the things we're really proud of that have worked, that we want to shine a light on this year, in the Toronto community, in the Ontario community, in Edmonton, and Winnipeg? And then what are the things we still need to focus on in the year ahead? And every year you'd be able to say, okay, so the sector's done great work in this area, challenges still remain in this area, and that would hopefully get both philanthropic funder attention as well as government attention.
So just to wrap up, I want to ask you, even during this very painful and challenging time with the pandemic, are there any potential changes or lessons that we've learned as a consequence that could be viewed as a positive development as it relates to mental health and the mental health of the people in the nonprofit sector?
Yeah, I mean, for one thing, we've learned, as I think Dr. Weisenfeld said, that people are inherently resilient. So, most people carried on, or in fact did more than they were doing previously. And we saw, great innovations in service delivery that weren't restricted to the community mental health sector, but, we saw it certainly in the meetings I attended, I saw it cross-sector, where, again, moving to online service delivery, increased access for many people. So I think what we've learned is that, and it sort of supports what we already knew, is that, humans are adaptable, and they are resilient. At the same time, we also have seen, non-traditional approaches to service delivery take hold and be effective. So, for example, the CMHA Food Box program. If you'd have asked my staff a couple of years ago, do you think it's important that you focus on, are your clients eating properly and can you help them eat healthy food? That wouldn't have been part of the job description. It now is. So, I think those are innovations that work. We found that, in terms of supporting our clients as well as some of the online stuff we were doing, we had some of our peer support staff do weekly or daily wellness checks with people just over the phone. How are you doing? And just that human contact. It didn't cost a lot of money. We were already paying the staff, but we basically built in to their daily activity. Can you call, the people you've been working with that you maybe were seeing previously, a couple of times a month? Call them once a week or daily if needed and provide that support. And that worked really, really well. So I think probably lots of organizations uncovered things that they wouldn't have thought of doing prior to the pandemic that now they want to keep doing. And, one of the stars of our NGO sector, the late Brenda Zimmerman, who trained and consulted with a lot of us on chaos and complexity theory. She used to identify that a really important two really important questions around strategic planning or strategy in organizations, and one is, what do you want more of? And the second question is, what do you want to stop doing? And it seems to me that if organizations in our sector reflect on the last 18 months about, okay, what do we want more of? Because we've learned things that really work, and so we want to scale these things up. And then, what are things that we've learned don't work, and we need to move on? Like, that'll move the sector ahead. And again, creating some tables in local communities where people, across sectors shared that kind of information and discussion will create lots of opportunities for collaboration.
Well said. Thank you very much, Steve, for your insights and your leadership and commitment over the years to mental health in Canada. Thank you very much for sharing your thoughts with us today.
Well, Mary, thanks to you and your production team for making this happen. And I hope people find the content helpful. I know you're also going to be posting some online resources for people to access. I mean, this is a really important topic, and I want to thank the Centre for Philanthropy and for you for your leadership in bringing this to the public's attention.
Thank you again.